Welcome, welcome. Welcome, everyone. Thank you so much for joining us on this lovely Thursday. I feel very lucky to be here, and I can't wait to discuss a case with you all and the one and only Robbie. Um, so please, if you don't mind volunteering, it's not going to be the same without you all. So please feel free to jump in. We would love to have two discussants and also a case presenter. So please put your name in the chat. We would love to hear from you. In the meantime, I will pass the mic to my run-loving, chocolate-loving friend, Robbie.
Hello. Good morning, everyone. Hi, Charmine. Hi, everyone. It's so great to see you all. I have a moment to share with you. I wish I could. Nah, it's too complicated. It's a picture on my phone. So sometimes everything in the world is perfect for like a brief second, you know? All of us have something that we wish was different. Like right now, I wish that I was with all of you in real life, for example. But that cannot be. But for like a second today, everything was perfect. And here's the description. I'm 20 minutes ago, I'm running on the beach in San Francisco on the sand. It's just the right texture. It's not too soft, not too hard. The water's like barely making contact with the right side of my foot. I'm running. And all of a sudden, usually, my dog, who you may or may not know, but if you don't know, that just means that we haven't hung out on VMR because I talk about him all the time. His name is Nar. He's usually either ahead of me or behind me. But there he was, exactly right next to me, running like a crazy dog in the grass right next to the beach. And he was keeping pace with me like to the beat. And so I tried to make it the perfect moment by seeing how much in sync he was. And so I would run faster and he would, like, without missing a beat, just be right there. And I would slow down without missing a beat, he would be right there. And this lasted for a whole 3 minutes until I had run so fast and so slow that I was exhausted. And this beautiful, blissful moment came to a premature halt because I have way too much chocolate. I could only sustain a pace to keep up with this dog for about like a minute or two before I petered out. But it was beautiful. It was like two beings, different species, in complete sync with each other. Both like probably 30 meters apart, but like in complete sync. And so my hope today is that we all are in complete sync in a different way. And to do that, again, I will call out for a case presenter and two folks to join us to all be singing our medicine tunes. To reflect on yesterday, yesterday was a fantastic case, and I don't want to spoil it for you, but I will tell you it has something to do with fever of unknown origin. So there's two parts to the term fever of unknown origin. One, your patient is febrile, and two, you don't know where it's coming from. And the first former is much easier to demonstrate than the latter. You often know your patient's febrile because you've shown that they've spiked a fever. What unknown origin means is tricky because it means you've tried hard, but you haven't found the source of the infection. Now, you can imagine that it's very subjective. How hard you try determines, because everyone's fever begins without an origin, and a certain amount of effort can clarify said origin. So what is it, strictly speaking, to have a fever of unknown origin? Well, it turns out that there's a sneaky third criteria that is easily forgotten about. And that third criteria is that you have to have tried, you have to have fever, that's two. But the third is the fever has to have lasted for 3 weeks. So not only do you have to have tried, the fever has to have persisted for 3 weeks. And the reason we do that is because if a fever is ongoing for a week or two, it will likely resolve before week 3. Now, how does the fever, without us knowing it, resolve by week 3? How does something self-resolve by week 3? And that's because most fevers, if they persist like this without gaining clarity, are often viral, and most viral infections are acute and do not result in a chronic infection. So in other words, we use fever of unknown origin to limit the criteria to 3 weeks because we know that most viral NOS infections disappear and no longer cause a fever by week 3. In other words, most viral infections cannot be chronic. So my challenge to you, dear chat and folks here, is can you come up with a way of organizing viral infections that can be chronic? In other words, viral infections that can cause a fever of unknown origin? Let's take a minute or two to do that. So folks in the chat, jump on in with thoughts and I'll share with you a schema to think about it in a moment. So I'm going to pause for 30 seconds. Megan, plead for synergy with a case discussant and a case presenter, and then see what the chat comes up with. All right, so 15 seconds, and we'll reconvene while I load the schema. We've got 2 of the 4 categories. Keep it going. What else? Yes. CP Solver's team represented. All right, one more. One more category. I see some pensive looks. We got HIV. We got herpes viruses. Oh, Shield, great thought. Adenovirus can be chronic, but in most people, it's self-resolving. Come on, dream team. I'm going to give you, oh, yes, HTLV is similar to HIV. It's a separate category. Idiopathic, great guess. If you're stuck, just say idiopathic. All right, I'll give you a clue. Immunosuppressed, subacute brain failure, and demyelinating disease. It's an infection that causes subacute demyelination in the brain. Gabby's typing, JC, yes, boom. All right, let me show you. All right. Are you going to be kind to me in return by somebody presenting a case? Please, please, please. I don't have pouty eyes, but if I did, oh, I would totally deploy them. Who has pouty eyes? Jump on in, please. But here you are. There are many chronic infections. Let's focus on the viral ones. The herpes viruses, a long list of them. Hepatitis viruses can cause chronic infections. Retroviruses like HIV and HTLV1, and then polyomavirus, JC or BK. So fever of unknown origin is designed to limit all the viral infections to just these. And only a few of these actually cause fever. These, for example, don't cause a fever versus all of these, which definitely can. Okay, all right. Marcella has a kiss. Yes. All right, I'll hand the mic back to Charmaine so I can inhale my cherries before we jump in to introduce our dear friend Marcella.
I'm so glad, Marcella, you have a case. How are you doing, friend?
Hello, everyone. I'm doing well.
And for those, for the people who haven't had a chance to meet you yet, do you want to reintroduce yourself to the VMR community?
Okay, sure. So my name is Marcela. I am a medical student from Brazil. Actually, I will be a doctor in 3 weeks. So I'm excited. Yeah. So can I start?
That's awesome. We're so glad you're presenting a case, Marcella. Who wants to discuss? Marcella has a case. Anybody wants to jump in with Robbie and I? Oh, yeah, Simone. Yeah, absolutely. Oh my God, Simone and Kiara. Yeah. Oh my gosh, this is going to be so fun. Yes, please. Simone, Kiara, I know the VMR community know you best, but you want to just say hi?
Sure. Hello, friends. I'm Simone. I am an intern in family medicine at UCSF in San Francisco General for only 2 more weeks.
Hey, Kiara.
I'm actually a doctor, I think, because yeah, I'm actually a doctor, and Yeah, I'm from Peru and I'm kind of oxidative. I haven't discussed since a lot, so I'm nervous.
Kiara, I have a correction. You are a boss lady doctor. Yes, you are.
Oh.
I
Thank
am
you.
so excited for this. Should we Kiara, Simone, thank you. Marcella, it'll be a lot of fun if y'all want to like take over the screen and get started. Um RG, do you want to take the first aliquot? I'm whatever you want to do. Okay.
So the chief complaint is fever. So do you want me to keep going?
Just a little bit more, if you don't mind, Marcel.
Okay, it's a male, 23 years old. So 3 days ago, he started with fever, with chills, malaise, and myalgia. He also reported an important headache. 2 days ago, he started with abdominal pain, nausea, and vomiting, and worsening his headache. Today, he presented with sudden amaurosis and decided to go to the hospital. So, in the emergency room, he showed spontaneous partial improvement in his visual condition, but he was maintaining a fever, asthenia, myalgia, especially in the calves, according to the patient, and abdominal pain with nausea and profuse sweating.
What doesn't he have, my friend? Everything. May I just ask one question before I pass the mic to Kiara to weave her magic? Is the vision loss in one eye or both eyes?
One eye.
Okay, do you know which eye it is? I'm not sure it matters actually, but I don't know.
No, I don't remember which
Okay,
one.
let's pretend it's the right eye. All right, Kiara, what are you thinking?
Well, I will start with fever. Maybe then I can do some kind of Venn diagram and with headache. So fever, we all have our amazing schema from CPS. Fever, sometimes I can translate it into infection, especially with this HPI, but I won't rule out anything and I can start with infection. Then malignancy is a little less likely because of this patient age. Some autoimmune diseases, especially yes, she is a female. Any drugs we don't know yet, and endocrine diseases, right? So as this patient has fever and chills, malaise, it's very likely for this concern to be um, something infectious, right? So I can I don't know what to do because this can be, I don't know, maybe meningitis, probably also encephalitis, also maybe some upper respiratory infections. I don't know where she is from, but if she is like from a tropical country like in Peru or Brazil, maybe some um, infections, diseases like from there. I don't know what else to do.
No, I think you're zeroing in on the pertinent abnormalities, my friend. I think the fact that the patient's inflamed has to be something really, really important, and I love that you emphasize the 4 key questions. I'm curious what you think about the vision. How does that help you?
So she has a vision impairment, right? So
Yeah, in just one eye.
just in one eye. So maybe this can be a localized lesion, like some disease affecting the brain itself or the chiasm or any kind of any part of the axis, or this can be like some mass compression, like brain edema or something like that.
Beautiful. I completely agree with you. I think I will leave that to be and reflect on something else about this, which is the reason this is hard is there are literally features of inflammation from head all the way to the toes. This patient's eye is affected and his cuffs are affected from here all the way to here. And the question is, what do you do with that information? What do you do with the fact that every part of the body, almost all his body, seems to be involved? The chest, the abdomen, the head, and the calves. And that takes us into reflecting about infections, really, and putting them into two different categories. You can either have an infection when an organism which lives normally on your body, like Staph aureus, takes over and becomes infectious. So when a commensal organism becomes an infectious organism, it usually causes a localized infection. So Staph aureus will infect the skin, cause an abscess. Strep pneumo will infect the lungs, cause pneumonia. E. coli will infect the GI tract, cause colitis. Klebsiella will infect the urine, cause UTI. Very focal infection. There's another category of infection, which is infection by something from the environment, something which usually does not live in your body. These are all the viral infections, things like Legionella, things like syphilis and leptospirosis and TB, where they come from the world and into your body. And those infections we don't usually control very well. Why? Because we're not used to them being on our body, and they are more likely to cause a disseminated disease process. So here, we should assume that fever equals inflammation equals acute inflammation is fever. And when fever has no center of gravity, you have to worry about an environmental organism much sooner than you usually would. And so here the priority is to consider viral infections and environmental bacterial infections and environmental fungal infections. But the caveat is that sometimes a commensal organism like staph makes it into the blood, and that's how it gets everywhere. But when an commensal organism like staph makes it into the blood and goes everywhere, it usually takes more time. Endocarditis usually presents almost 1 week, 2 weeks. So the fact that we have an abrupt disseminated syndrome from time zero, this thing, which is likely an infection, is everywhere, means that the odds are we're dealing with a disseminated environmental organism, something from the world. And how can the most helpful clue vision loss help us? I would say that the fact that it's only one eye means that it's anterior to the optic chiasm. And the fact that it's painless means that it's posterior to the lens. So whatever disease process, because it's painless, is probably posterior to the lens, and because it's only one eye, it's probably anterior to the optic chiasm. So you're between the retina and the optic nerve. So either this is neuroretinitis or this is optic neuritis. And that exam will help us localize it to the retina or to the optic nerve. And that will help us generate the list of possible infections it could be. But I'm right there with you. Inflammation equals fever. Fever, you have to understand the four key questions. And I would say the fact that it's disseminated so quickly and so early makes it suspicious that something from the environment has caused this. And we'll see what the eye exam shows us to help us make more progress. But I'll hand the mic back to Marcelo now.
So he didn't have any previous diseases, no allergy, no medication. He lives in Brazil, Minas Gerais. He's single and he reported unprotected sexual activity. Continue with the physical exam. His blood pressure was 124 above 70. Heart rate was 103. Respiratory rate 22. And oxygen saturation 93 in room air. He was icteric, mild icteric, dehydrated, no pallor, normal conjunctive. The cardiovascular system was normal, pulmonary exam was normal. In his abdomen, he had diffuse tenderness to palpation in the right upper quadrant. hepatomegaly, 2 centimeters under the right costal margin, and no splenomegaly. The neurological exam was normal, and he had the presence of well-defined purpuric lesions, painful on palpation. It didn't disappear on digital pressure, and it was mainly in the extremity, like hands, feet, and nose.
Woof, what a case, Marcella, and what an epic discussion, Kiara and Robbie. I'm just gonna stay silent and pass the mic to the one and only Simone.
Hello. Okay, so going into this aliquot, I was sure we were going to be talking about somebody with like some level of immunocompromise. Like we were going to tell me this is a person with HIV, and it was going to make sense how they had developed this like disseminated infection in this young person. But turns out that was not the case because he has no known past medical history, and he's not on any immunocompromising medication. So that takes sort of, now that I understand the host that I'm working with, I'm thinking of something coming from the environment, and less likely that's been smoldering there for a long time, but rather like a newer insult. In terms of the social history being from Brazil, I don't have enough familiarity with sort of the endemic pathogens of that region. So I'm hoping that somebody else here can help me with it. No health-related behaviors that are particularly helpful. Looking at his vital signs, I also expected this to be somebody who was rather sick coming into this aliquot, and the vital signs don't kind of point me one way or the other. The heart rate is mildly elevated. The O2 saturation is mildly low. They're not somebody who immediately I'd be super worried about. But then we get to the exam, and the first thing that sticks out is this icterus. So when I think of icterus, I'm thinking of icterus being bilirubin, like how did this bilirubin get here? And either thinking sort of like pre-hepatically, it could get there by hemolytic process, so the breakdown of red blood cells leaving bilirubin in the bloodstream, or sort of like intra or post-hepatically, something in the liver that is like congested and stopping sort of the conversion of bilirubin to its soluble form, or something after the liver that's sort of blocking its passageway out. And at this point, I don't yet know where that sort of problem is. And then as I get to the abdomen, I see that there's right upper quadrant tenderness and hepatomegaly. So now I'm thinking the liver is big as well. So maybe the problem isn't primarily hemolytic, but I'm not sure that's quite enough to convince me of that. And then I see purpuric lesions painful on palpations. So when I think of it doesn't tell me if it's palpable purpura, but I'm hearing from this palpable purpura, which makes me think of a vasculitic process. And so now I've got some sort of elevated bilirubin and a vasculitic process. And somebody in the chat a long time ago said leptospirosis. So I have to say that that's on my mind, because when as it's just like tinkering there. And especially, we have this like diffuse multi-organ process, it seems like, multi-organ inflammatory process, which I think definitely, other than diseases disseminating through the vasculature, another way that you can get that is the vessels themselves being inflamed. So those are the things that are on my mind. Charmaine, help me.
You don't need any help. That was fantastic, Simone. I 100% agree with you. And the reason I love like this exam and its background, especially the exam, is that you have to think about indirect hyperbilirubinemia, thinking about palpable purpura, and kind of the Venn diagram of like what lives in that category. And I really, really love, Simone, that you always like pay so much attention to the health related behavior and social history as well. And I think like whether this patient is immunocompromised or not just like helps us better frame this patient going forward. And the only thing I would add is that, a 23-year-old, they're not particularly good at going to doctors. So even if he had like any exposures or anything, she might have just not presented to care prior to this. And so I still think your idea of like making sure to get an HIV test and just to check for like STIs is very, very valid. And moving along with on the exam, I I have nothing to add to your incredible discussions. I think mild icterus also with the hepatomegaly and the right upper quadrant tenderness makes you think about the biliary tree and both running the list of indirect hyperbilirubinemia. Robbie had a great discussion on the Friday VMR about the clues for indirect hyperbilirubinemia versus direct and on history that we don't have here there. So I think, again, I agree with Lovey that liver is just awesome. So we will have the test to show us which belief we're dealing with, so we can better effectively run the schema for indirect hyperbole versus direct. And to think about the purpuric lesions that the vessel walls are inflamed, whether we're dealing with an infection, whether we're dealing with a primary autoimmune disease. And one thing that, with the eye finding, this like systemic inflammation that I always like think about is like endocarditis as well, that can have both skin manifestation, that have embolic phenomena. We don't hear a murmur on this exam as well. It's another thing to consider. Plus our like systemic infections. It would be kind of nice to know more about. Oh, here we go, exposure to cats and dogs. So that like Bartonella, like your back, all that jazz is on the table. So I think once we have the labs, we can better go forward with our Venn diagram of like, hey, is this a more hemolytic process that we're dealing with? Is this more primary liver issue that we're dealing with? And hopefully with that, we can make some diagnostic progress on how to marry this palpable purpura and the liver better. Okay, awesome job, Simon. You're such a boss.
So we also did a fundoscopy exam. It showed bilateral suggestive signs of vasculitis with discrete points of local bleeding. No other neurological deficits in the exam. His hemoglobin was 13.5, hematocrit 37.8, MCV 5.5, platelets 91,000, leukocytes 7.3 thousand, with 70%, 60% of them neutrophils, 2-3% neutrophils, 10% lymphocytes, and 7% monocytes. His INR was 1.12. Urea was, BUN was 14.28, creatinine 1.07, sodium 140, potassium 3.71, C-reactive protein was higher than 35. Total bilirubin was 5.19. Direct was 4.654. Indirect 0.65. Alkaline phosphatase 142. AST 113. ALT 144. GGT 421. Amylase 26. And lipase 30. Urinalysis, it was orange clarity with mild leukocyturia and microscopic hematuria, granular cylinders, and no other changes. Now stop here.
Dr. Chiara, hello.
Why I got the laughs.
I know this case is so hard and so complicated. I think we should just talk about each thing and then afterwards try to put it together. So what are you most confident about, and what is the most striking thing to you about this case? And let's just take one piece at a time, and then we could try to connect the dots.
You're right. Maybe I just can like start reading and think and say my concerns. That okay? So yes, platelets are low, so I'm concerned about liver disease. First, because I can read it on the chemistry exam that liver disease is one of my big thoughts right now, and then um, okay, so we have a high bilirubin. It is mostly direct bilirubin. I know you like liver diseases, so I can say with that that we have a conjugated uh, hyperbilirubinemia, and with that this can be caused by at least three things, right? So one is that maybe this is like a biliary obstruction. Second, this can be like a hepatocellular damage, or third, like less likely a like hereditary defect. Um, so starting with the obstruction, this is I think this is one of the most common ones. This can be a choledocholitic, some pancreatic disease causing a biliary obstruction, but I still like top of my thoughts an infection, right? So this can be anything causing a biliary obstruction, but with an infection disease. Then with hepatocellular damage, first things are common, so this can be an alcoholic or viral hepatitis, but probably not in this case because the AST and ALT do not reflect like hepatitis or alcoholic pattern. So then this can be caused by drugs, abscesses. This can be probably I I don't know, and some other like infiltrative diseases like TB, sarcoid, lymphomas. I don't know what else to. I'm like a bit concerned with abscesses because if there is something going on with the eye and there is something going on probably with the lungs because his SpO2 is low and something with the liver, I'm thinking about some metastatic disease like even infection or um, like cancer. So yeah, I don't know what else to do. I'm sorry.
That's absolutely brilliant. I really like, especially like how you simplified hyperbilirubinemia. You're like, it can only be three things: either extrahepatic obstruction, hepatocellular injury, or a congenital defect. And I think that that's such a simple way of thinking about such a complicated problem. I also liked how you're keeping the focus of inflammation on infection, but you're not forgetting infiltrative diseases like sarcoid and lymphoma. And I think the question for us is, all these things that you just talked about still have a long differential diagnosis, but there's a word in the eye exam, and it says, I'll read it: bilateral signs of vasculitis. I'm going to ask you to be honest. Do you think this patient has vasculitis?
Mm,
Okay, let me ask you a different question actually.
okay.
Why are you hesitant to call this vasculitis? Because you just went, hmm. So why aren't you running to say this is vasculitis?
Well, so we have a high CRP, but CRP can be, of course, high in vasculitis infection or anything.
Yes.
But vasculitis can compromise many organs. We
Yeah.
can evidence that, but and also can produce amaurosis. But I'm not so sure if. But in this case, amaurosis is in one eye. I'm not so sure if it can compromise liver. So I cannot rule out, but little less
Yeah.
likely. And also this is an acute cause, right?
Yes.
So it's less likely to be from vasculitis.
I'm gonna give you a standing ovation, but I'm so sorry for my. Just accept it, a sitting ovation.
You're
I'll
too
tell you.
kind.
Can I cheat and tell you, this patient doesn't have vasculitis because of one thing for sure. There is no cause of vasculitis. Okay, let me explain first. When we say vasculitis, it's confusing because you're just saying that there is an inflammatory vascular problem, but that's not what we mean. When people say vasculitis, they mean autoimmune vascular disease like giant cell arteritis, etc. And you may think, well, are there infections that can infect vessels? Of course, but that's not what people mean when they say vasculitis. When they say vasculitis, they mean autoimmune primary vascular disease. There is no vasculitis under the sun that causes thrombocytopenia. All of them, if they're going to affect your platelet count, will cause thrombocytosis. In a landscape that is concerning for a vascular process, and the evidence for a vascular process is strong because of purpura, microscopic hematuria, and eye findings suggestive of vascular disease process. It's a good operating assumption. But the presence of thrombocytopenia is a big red flag against the diagnosis of vasculitis. Are there exceptions? Yes. Lupus, for example, if uncontrolled and undertreated, can cause a vasculitic syndrome, and lupus notoriously causes thrombocytopenia. But careful, if you see a vascular signature of the disease that is inflammatory, look at the platelet count. If the platelet count is low, press the brakes so hard, because that should be the hardest stop sign under the sun. And so the question then is, well, how does thrombocytopenia steer the ship? And thrombocytopenia is either a great help or a big pain in the butt, because thrombocytopenia can be present because of inflammation NOS, sepsis NOS. Hyperbilirubinemia can also be present from inflammation NOS or sepsis NOS. Both sepsis and direct hyperbilirubinemia can be attributed to cholestasis of sepsis and thrombocytopenia of acute inflammation. So they may be very nonspecific, but the combination of them is evocative of a small number of infections that can cause both liver issues and platelet issues. And the list is very short. The list is some very uncommon viral infections like dengue and yellow fever, and some very few bacterial infections, most notably Salmonella, Bartonella, and Leptospirosis. And then you have to think about malaria and babesia, though usually those are much more indirect hyperbilirubinemia from hemolysis. So if you take the combination of direct hyperbilirubinemia and thrombocytopenia in the context of acute inflammation, you would prioritize dengue, yellow fever, Salmonella, Leptospirosis, and Bartonella. Okay. Now, how can you make progress on all of those? Well, it's hard to. It's hard to. But of those infections, the most likely to involve the eye are Leptospirosis and Bartonella. Bartonella is usually not so acute and not so hectic. Bartonella can be disseminated disease like Gabrielle taught us a long time ago. But if you remember Gabrielle's case from maybe a month ago, it was weeks, not 3 days. So here, I think you really have to worry about leptospirosis and worry about it quickly, because it is one of those doxy-responsive diseases that we talk about a lot. The lay of the land is still very broad, but you have to think about an unusual cause very early on, because without treatment, patient can have significant consequences. So I'm right there with you. I think we have to think about all the mimics of vasculitis, ranging from endocarditis to aortitis. We have to work up the direct hyperbilirubinemia with a CT scan to make sure it's not obstructive. But the combination of direct hyperbilirubinemia and thrombocytopenia that is acute is very worrisome for those short list of infections, and we'll see where this case goes. Alrighty, back to you, Marcella.
So I have one more adequate before the final diagnosis. We did some serology, so HIV was negative, hepatitis negative, and VDRL negative. And he had an MRI. It had small focus of intraparenchymal hemorrhage in the portion of the pre-stinctal gyrus of the left frontal lobe, associated with signs of subarachnoid hemorrhage in the high frontal parietal convexity, especially the left.
Hey, Marcel, is that the end of the aliquot?
Yes, I don't have more exams because a professor who saw this patient, she suspected about one disease and did an exam that revealed it.
Awesome. All right. Whoa, Simone, first of all, Kiara and Robbie, boom, that was fantastic. And the thrombocytopenia pearl about vasculitis is like one of my favorite pearls I learned from Robbie. Simone, where you at, my friend?
Yeah, so Robbie, I think, made a very convincing case for leptospirosis, and I'll just talk about how this maybe changes or it doesn't change my thinking. So the serologies for HIV, Hep B, and EBV make sense to me. Those I think of as more subacute infections. HIV can present really acute, look like a really acute viral syndrome, but typically those are subacute infections. So it wasn't necessarily what I was thinking of, though they do affect the liver, so it makes sense. In terms of the brain MRI, so there's a focus of intraparenchymal hemorrhage, and the bleeding in the brain, I think I'm still trying to work out if I think this is a cause or an effect of these symptoms. Like this is somebody who who has thrombocytopenia, making them more likely to bleed, who has potential vascular inflammation, making the vessels more leaky and more likely to potentially bleed. And so in those cases, maybe this is just an effect of the underlying process and we don't need to change what sort of the strong case we had made. On the other hand, the question is, what is causing, is there something else causing these hemorrhage or causing these vessels to be weakened? Like, was there a mass or some sort of insult? But I am not super convinced that they were, only because the presence of something focal just in the brain wouldn't help me really make progress, wouldn't help explain to me sort of cholangitic picture that we had previously. And so I think that I'm thinking about this as more of an effective vessel inflammation that as part of my prior illness script, and still prioritizing the infections that Robbie had convinced me of. But Charmine, what do you have to add?
I am right there with all of you. I think so. Intracranial hemorrhage is not what I had in my like lepto illness script, but like lepto you can call it DAH. So I think if you I wonder if like a severe lepto can also cause intracranial hemorrhage, and oftentimes like also worrying about co-infection as well, whether this is lepto plus something. I like previously have like come across an article about like I think a dengue plus lepto co-infection that had preceded, but by my mind I had attributed the intracranial hemorrhage more to dengue at a time when I was reading that. So I think this is a, given all the things we've talked about so far, is a good case for lepto, and I do makes me pause to wonder about another co-infection at the same time. Again, like my illness script is quite limited. So I would love to hear from Kiara and Robbie as well to see like if this fits in their thinking, or are they invoking like a co-infection potentially?
Kiara, what do you think?
That I love the case. And well, my thoughts. So I'm not so sure if this intraparenchymal hemorrhage can be due to low platelets, because it's 91, right? Maybe a lower platelet count can be causing a hemorrhagic intraparenchymal hemorrhage. So in that case, it makes a lot of sense that this is like a co-infection with something else like lepto and dengue. We don't know if this patient had exposure to rats, but rats is not the only animal that is. I mean, leptospirosis is just animal infected with that, and the patient is exposed to its fluids. So this is a very likely case and fatal case from leptospirosis.
My dear friend, I am right there with you. I think we have to step back and be honest. In this in this case, what are we confident about? We're only really confident that we should test for leptospirosis and test for dengue and look closely for them. Um, and the truth is that we wouldn't be surprised if this turns out to be endocarditis with a subtle murmur causing vasculitic infection. We wouldn't be surprised if this turns out to be another vasculitis mimicker with all the infections that you pointed out. And the truth is, all that we can do is to try to get the most accurate problem representation, which is a young person with no immunocompromising conditions, with an acute syndrome characterized by vasculitic features, direct hyperbilirubinemia, and thrombocytopenia. And endocarditis, leptospirosis, and dengue are all consistent with them. And I'm collapsing everything that suggests a vascular problem with the brain, eye, and skin, and kidney. And what is actionable? Dengue isn't so actionable now. There's not much good treatment for it. Lepto is actionable because you can give doxycycline, and following the blood cultures to make sure there's no endocarditis is actionable because you can get a different antibiotic. So no matter what, no one can claim to know what this patient has, but the wrong thing to do would be to not suspect lepto and not to give the patient doxy even before the test comes back, I think. What are some clues that point away from dengue is when dengue is this severe, patients usually have vascular leak. They have ascites, effusions, and their hemoglobin goes up. That is not a feature of leptospirosis. So where does this case land? I'm not sure. But what I'm more confident about is the need for close blood cultures, the need for doxycycline potentially, and then to stay vigilant and open to the many possibilities this could be. All right, Marcella, back to you.
Beautiful.
So that was exactly what they did. So in the culture, grow 2 positive samples for Staph aureus, and we did an echo, and he had a vegetation in the mitral valve with 2 regurgitation jets, and the final diagnosis was endocarditis.
What a case. Endocarditis, man, always, always the most humbling of the diagnoses. And this is a good case for it. Absolutely. Wow, Marcella, thank you so much for presenting this case. I feel like no matter how many cases of endocarditis I hear, it's one of those things that humbles me. In addition to lupus, my other good friend that we're a little bit frenemies. Simone, Kiara, Robbie, any reflections?
I will say that I wish I could more quickly unlearn step 1 and step 2's guidance to say, is it A, B, C, D, or E? And really the only truth that you can ever obtain in medicine is representing the problem correctly. And I think when you represent this problem as an acute a vascular disease of some kind that has inflammation, you can cast a wide net. And this very case could have turned out to be culture negative leptopositive, could have turned out to be culture negative leptonegative dengue positive, and no one would bat an eye. They'd be like, oh yeah, the hemoglobin was a little high for dengue, it's hemoconcentrated. I expected it to be 10 in someone this sick, but it's 14. Or you might have said, oh, this patient has normal valves, normal native valves. There's no way they can get endocarditis. Everything you can rationalize. And so I encourage you all to remain vigilant, not on what is happening, but on not what the answer is, but what the problem is. If you represent the problem correctly, you'll be least likely to make mistakes. And that's the humbling reminder of this case for me is focus on the problem, not the answer. And if you get the problem clearly enough, then you'll be less and less likely to stray.
Yeah, That is beautifully said, my friend. And the other thing is like, where is the stuff coming from? So it would be cool to go back and talk to the patient a little bit more about like what is the potential entry point for that stuff. What a case, Marcela. I'm gonna be reflecting on this for a while. Thank you so much for presenting. Simone, Kara, I'm just such a big fan of you all. You're both incredible. Rafa, can't wait to hear your teaching points. Thanks, RG.
Yeah, I've heard this case before, and it really blew us away the first time that we saw that. So try not to give any hints. So we had a fever in a young male patient with visual abnormalities in one eye. And then when it comes to fever, Karen managed to think about the eye mnemonic, which stands for infection, malignancy, autoimmune drugs, and endocrinopathy. There are always those 4 key questions that you have to make when we are dealing with fever. So who is your patient, especially the immune status? Is this patient HIV positive or not? Was he born with like a congenital deficiency? Which is the clinical syndrome? Which is the epidemiological factors that this patient may be exposed to? And when, which is the time course. We always say here that time is queen. And then we saw that this patient had amaurosis, which is transient vision loss, which can be monocular or binocular. Monocular, Rabbi reminded us to think about disorders anterior to the optic chiasm, including ocular disease, ischemia, ipsilateral carotid artery disease. Binocular, we could think about, if it was binocular, we could think about optic chiasm, tract radiation, or the visual cortex being injured. So we saw that this patient had hepatomegaly, tenderness on the abdomen, and jaundice. When we are dealing with jaundice, we have to rule out emergencies first. For example, cholangitis, acute liver failure, and hemolysis, especially in a setting of MAHA, like GIC, TTP, HUS. And then we divided the bilirubinemia in unconjugated and conjugated. Unconjugated, we could think about overproduction, like hemolytic anemia, we thought about that, or defective conjugation, like Gilbert, but also in the setting of heart failure and drugs. Conjugated, there's this exam that it's very special to use here, which is the abdominal ultrasound. So it can look for bioductal dilation. If there is none, we could think about intrahepatic causes like cirrhosis, hepatitis, infiltrative disease. And if there is bioductal dilation, we could think about extrahepatic causes like stones, parasites, cancer, autoimmune. And then Rabbi made this case that it was probably not vasculitis. So we asked ourselves, why not vasculitis? This wasn't an acute process, and none of them could lead to thrombocytopenia. They usually lead to thrombocytosis, which is reactive thrombocytosis. And then we saw that this patient had fever and jaundice, and we tried to combine those features. And thinking about infections that could lead to fever and jaundice, we thought about malaria, lepto, bartonella, dengue, Zika, chikungunya, hantavirus, yellow fever. And finally, we saw that this patient actually had endocarditis, which is the inflammation of the endocardium that lines the surface of the cardiac valves. And it's usually due to bacterial infection, which was the case, Staph aureus, but we have to remember non-bacterial thrombotic endocarditis. There are sterile vegetations associated with hypercoagulable disorders. So thank you, everyone. This was such a very nice case, and I hope everyone enjoyed it.
Whoa, Rafa. Thank you all so much. This is so fun. It's such great learning. Thank you. You guys made my day. Have a good one. Bye.